Hello.
Hello?
I'm just logging into the conference.
Okay.
Okay, I should be here now, I think, Sandy.
Hello.
Hello.
Hi.
Participant lines muted.
Hello, everyone. Hello.
Hello, everyone. Laura, are you there?
Yes. Can you hear me?
Yes, we can.
Okay, good. So now I'm going to try to put in this code that it's telling me to enter, and we'll see what happens. Okay, so that box now has disappeared. I think in theory we're synchronized.
Participant lines unmuted. Participant lines muted.
Hi, Laura. Can you still hear us? And could you just say hello?
Hello.
Perfect. So you're logged in as moderator. That's fantastic. So I'll turn it over to Sandy in a moment, and we'll get started.
Okay, sounds good.
Hi, good afternoon, everybody. Welcome to today's Born Provincial Rounds. My name is Sandy Dunn. I'm the Knowledge Translation Specialist at Born, Ontario, and I have great pleasure today in introducing our topic and our speaker, Dr. Laura Godet, who's going to share some very interesting research she's done in relation to neonatal outcomes. As you can see from our flyer that went out before, the title of her presentation is What to Expect When You're Expecting an Infant from a Mother of Size. So before we hand over the mic to Laura, I'd just like to tell you a little bit about her and cover a few housekeeping points about the way we will run the rounds today. As usual, what we prefer to do is to have the presentation given in its entirety, and then we will go to a question and answer period after the presentation just to streamline things. You'll be able to pose your questions in the chat box on the upper left-hand corner of the screen. So later in the presentation, as we're getting closer to the end, if you have any questions for Laura, please start to type them in the chat box, and we'll monitor the chat box. With the slides and the presentation, the webinar is being recorded and will be posted on our Born website for observation or access for other people who weren't able to attend today, so that you can count on that as always. So moving forward then, just to tell you a little bit about Laura, Laura holds a Doctor of Medicine from Queen's University, where she also completed her residency in obstetrics and gynecology. She then undertook a subspecialty training in maternal fetal medicine and a Master's of Science in Epidemiology and Community Medicine at the University of Ottawa. Her thesis focused on the effects of maternal excess weight on infant birth weight and delivery room care of the newborn. Since that time, Laura has been involved in numerous research projects related to obesity and pregnancy. Laura is currently a perinatologist in Moncton, New Brunswick, and she's speaking to us from there today, where as part of her practice, she developed a clinic designed to help women with severe obesity to improve their pregnancy outcomes. Her most rewarding work, however, involves enjoying an active seaside lifestyle with her husband, Patrick, and their 4 young children. And I have to say, Laura is going above and beyond the call of duty today. She's dealing with illnesses in her household, and we appreciate very much her being able to be with us today. So I'll hand the mic over to Laura and let her go ahead with the presentation. Over to you, Laura.
Thanks, Sandy. I guess it's one of the hazards of having 4 young children is that they're fantastic little virus minds. I'm really happy to be able to present to you through this forum today. I think it's a really unique opportunity to get some of this data out there, and I hope that everybody enjoys the discussion, especially at the end. So without further ado, the first slide you should be seeing is the title slide, What to Expect When You're Expecting an Infant from a Mother of Size. And although it's a complete aside to what we're going to talk about, the mother of size part of that title came about a couple of weeks ago. I guess I've always struggled a little bit with what to say to women who are heavier than they should be. I think many women have a particular dislike for the term obesity, and certainly if we start discussing morbid obesity, that seems to have a completely negative connotation for these women. So about 3 weeks ago, I had a woman in my office who does attend our clinic, and it was the first time I'd met her, and we were just starting out, and as a standard, I measured her height and weight and calculated her BMI, and we talked about how that fell in the obese range. And she said, "Can't you come up with a better term for obesity?" She said, the pit of my stomach falls apart when I hear that. So I asked her what term she preferred, and she said mother of size. She said, we used to talk about people as being women of color. Well, this is more like that. She said, obesity does not own me, it's just part of me. So with Sandy, if we can go to the second slide. Working well. So there's 3 objectives to today's talk. By the end, we should, I hope, be aware of the impact of a mother's excess weight on infant birth weight. We're going to explore whether infants who are born to heavier mothers require additional resuscitative support. And then we're going to discuss preventative measures that will reduce newborn complications when the mother carries excess weight. Next slide. I think it's no news to anybody who's on this call that obesity is common in Canada, and it's common in all age groups. I selected this little photo to go on there. It's a 5-generation photo, and I think it's really important to remember as we talk about this that obesity is an intergenerational problem, and it seems to be getting worse over time as we look through generations. As far as obesity goes in Canada, there certainly is a gradation. We all know that. The lightest women tend to be on the west coast and the heaviest on the east coast. Hence, I guess I have some background in this to talk to you today. Go to the next slide. This data is about obesity in the general population in Canada. It's taken from the Canadian Health Measures Survey. So this is measured data, and I've got a black box there around adults of reproductive age, so ranging in age from 18 to 39. And while still most fall in the normal weight category, there is a little bit over 40% that fall into the overweight or obese category. And if you just glance to the right, as we get older, we tend to get heavier. Next slide. It doesn't stay in the adult population. This is data from the same survey, so measured data on children and adolescents ranging in age from 6 to 17 over the time period 2009 to 2011. And I think it's striking that more than 30% of our youth now are also falling in the overweight or obese category. This is substantially different than a generation ago. Next slide. I struggled a bit to come up with a straightforward definition for obesity, and so while I cringe a little bit to think that I'm using the Wikipedia definition, I'm using the Wikipedia definition. I like it. Obesity is a medical condition in which body fat has accumulated to the extent that it may have an adverse effect on health, leading to reduced life expectancy and/or increased health problems. There's a couple things about this definition that I like. First of all, it does diagnose obesity as a medical condition, and that's something that's been heavily debated in multiple different communities, but I think most people now agree that obesity should be considered a medical condition. The other thing that I like about this definition is that it doesn't give strict criteria for body fat. It just says if you're carrying body fat to the extent that it causes problems, that's a significant issue for you. Next slide. We know that obesity causes increased health problems in pregnancy. This is well documented, multiple studies. Some of the more common things that you'll hear about are hypertensive disorders, diabetes, macrosomia, intrauterine fetal death, delivery by C-section, and admission to the NICU for the baby. Next slide, please. We defined obesity. We'll also define macrosomia. So macrosomia is a term that describes a newborn who's significantly larger than average. Depending on where you're reading and what context you're working in, the criteria that actually defines which baby is significantly larger than average does differ. Probably the most common one in the literature is that definition of greater than or equal to 4,000 grams. There are a couple of sources now that have graded macrosomia as grade 1, 2, or 3. So grade 1 is greater than 4,000, grade 2 is greater than 4,500, and grade 3 greater than 5,000. And then you can also use a percentile definition. So much like small for gestational age, if you're bigger than the 90th percentile, then you're described as significantly larger than average. And next slide. There are well-identified risk factors for having a macrosomic baby. They include a history of a previous infant who was affected, maternal diabetes, post-term pregnancy, maternal obesity, gender, and non-smoking. And it's clear that being macrosomic causes complications both for mother and for infant. Next slide. This is data from 2001. This is all Canadian infants with birth weight greater than 4,500 grams. So 4,500 grams, just for reference sake, if we convert that to pounds, that's a baby who weighs more than about 10 pounds. You can expect 2.2% of baby boys and 1.1% of baby girls to be over that 4,500 gram threshold for an overall prevalence of 1.6%. Next slide. I put this slide in here because I want you to think about it, and again, hopefully it will be food for discussion afterwards. We gave you that definition for obesity earlier. That's it word for word copied over. I guess what I'm wondering is whether we could consider fetal macrosomia the same as fetal obesity. Something to think about. Next slide. So when I set about doing my master's thesis, we tossed around a lot of topics, and the idea of the impact of maternal obesity on neonatal outcomes came up. And so we developed this theme for the overall master's thesis of improving the health of pregnant Canadian women who carry extra body weight and their offspring. And under that overarching theme, there were a couple of things that we set out to do. Next slide, please, Sandy. So we wondered how large the effect of excess maternal weight is in increasing birth weight. We took that as a given. It's been demonstrated in multiple studies. But we were interested in bringing that data together and really firming up how much of a role excess maternal weight plays. And then as the second component of the thesis, we looked at whether immediate neonatal complications were more common when babies had mothers who were obese. That picture up in the corner taken by USA Today, you may have heard, that was about a year ago now. This woman went on to deliver this baby who weighed in excess of 14 pounds. And for anybody who's interested, she did deliver that baby vaginally with no problem. Next slide. as I mentioned earlier, it's been shown previously that in general birth weights are higher for babies whose mothers are heavier. In this systematic review of the literature component, we set out to examine the hypothesis that maternal obesity is associated with a significant increase in the prevalence of macrosomia, as defined by any one of the three definitions that usually would diagnose macrosomia. So we looked at 4,000 grams, we looked at 4,500 grams, and we looked at the 90th percentile. Next slide. We included in the systematic review all observational studies that defined obesity as body mass index greater than or equal to 30 kilograms per meter squared. That seems pretty straightforward, and yet there were lots of studies that didn't quite follow that same definition and therefore were excluded. We ended up using a control group of women with body mass index less than or equal to 25, so that does include both women of normal weight and underweight women. And we required studies to report usable numbers in order to include them. So basically they had to give us the numbers of obese women and macrosomic infants. Our exclusion criteria were fairly straightforward. We just asked that articles have an English abstract at a minimum. There were a couple that we excluded on that basis where there was no English abstract, and the translation got to be quite challenging. Next slide. So this is our usual flowgram for a systematic review. So initially we identified 285 articles, 4 of which turned out to be duplicates. So that left us 281 articles. When we screened the reference lists, we came up with an additional 14. And then there were 6 articles that we excluded, 2 that I couldn't get by interlibrary loan, 4 that had non-English abstracts. And that left us with 289 full articles that we reviewed the titles and abstracts of. Based on that, we excluded 259, and that left us with 30 eligible studies in the systematic review. Go ahead, next slide. So first of all, we looked just straightforward overall prevalence of fetal overgrowth, broken down by those 3 categories we talked about earlier. So putting together all of the literature values that we could find, overall 10.4% of babies are born weighing more than 4,000 grams. And if you isolate the women who are obese, you can see that the prevalence is higher among them at 15.8%. Similarly, for birth weight greater than 4,500 grams, in all of the reports put together, there were 2.1% of babies weighing more than 4,500 grams. That risk was almost doubled if the mother was obese. And then birth weight by the 90th percentile I always find interesting because it seems like, by definition, that should be 10% of infants. But as you know, we've shifted, the population has shifted while the growth curves have not, such that now 22% of all babies are born weighing greater than the 90th percentile. Certainly striking. I can't explain why the number didn't appear higher in obese numbers. When we ran that analysis, that's the way it came out. Next slide, please. So these are your standard forest plots that looked at the effect of mother's weight and birth weight greater than 4,000 grams. So if a mother has a body mass index of greater than or equal to 30, her chance of having a baby that weighs more than 4,000 grams is 2.17 times higher. And certainly the confidence interval there is significant. Go to the next slide. This slide has an error on it. That odds ratio at the bottom is incorrect. It's from the last slide. So this looks at mothers who are obese and birth weight greater than 4,500 grams. And the actual odds ratio there should be 2.77 with a confidence interval from 2.22 to 3.45. And so the effect seems to be even bigger for the heaviest babies that we see. And next slide. There's the 90th percentile data. So odds ratio again of 2.42, significant with the confidence interval shown. So in our minds there was relatively little doubt that being a heavier mother certainly contributes to having heavier babies. And it didn't matter which definition we used, that was certainly the case. Next slide. As part of the thesis, we looked at study quality, and I found this little graph to be quite telling. When we ran our study quality criteria through, the vast majority of studies were graded as moderate or low quality, with relatively few coming out as high quality. And so that plays a significant role in how we think about this data. If you go to the next slide, it shows the analysis now broken down by study quality. And I know there's a lot of data on here, and I don't want you to pick through it. The high-quality studies are at the top, and the moderate-low are running down the left-hand column there. It's interesting sometimes to isolate the analysis just to the high-quality studies, and in this case, there was only one study that was considered high quality, and the odds ratio from that one was fairly consistent with the overall odds ratio for 4,000 grams. Next slide. When it came to birth weight greater than 4,500 grams, we did have two studies that we included in that analysis. And in this case, if you only include the high-quality studies, your odds ratio becomes even more significant at 2.86 with a significant confidence interval. So I think sometimes it's really important to think about the quality of studies, particularly when doing a systematic review. And the next slide, please. Same concept now for birth weight greater than the 90th percentile. Again, two studies graded as high quality. And again, the effect a little bit more profound if you only include the high quality studies. Next slide. I think what's important to recognize from those last three slides is that there is highly significant and important heterogeneity. If you look at the I-squared values for all three measures, they are significant and demonstrate quite a lot of heterogeneity, something that's always a little bit of a problem when you're trying to put data together. So we ran a subgroup analysis that looked at whether we could decrease that heterogeneity at all. So the first thing we did was to include only high-quality studies, and that brought the heterogeneity right down to virtually nothing. And then the other thing that seemed to make a big difference was if you used measured height and weight, and that stood out particularly for those babies that weigh more than 4,500 grams. And that's maybe not surprising. We already said that we think that the heavier the mother, the more likely they are to have a baby that weighs more than 4,500 grams. And those women can be the hardest to measure and also the most inaccurate in their self-reporting data. Next slide, please. So the second part of the thesis, and this is where Born comes in, we set out to do a couple of things. The primary objective of the cohort was to determine the combined effect of macrosomia and maternal obesity on adverse pregnancy outcomes. So what we wanted to know there was, if you're an excessively large baby, is there any difference in your outcomes whether your mother was obese or not obese? And then we had some secondary objectives that were more descriptive. So we were looking at the occurrence of adverse pregnancy outcomes among macrosomic infants by maternal weight status. Next slide. As far as methodology goes, it was a retrospective cohort database study, and it was run using the Born data set. We had them isolate mother-infant pairs with a macrosomic infant, and for the purposes of this part of the talk, we talked about macrosomic infants as being more than 4,000 grams. We pulled all of those babies who delivered at the Ottawa Civic Hospital between December 1st, 2007 and March 31st, 2010. And that population was selected because as of December 2007, the Ottawa Civic Hospital was recording on all birth charts maternal height and weight, and so we could calculate BMI from that. And March 2010 was the time when I was working on my thesis, and so that became our close date. Next slide. We used the exposure variable of maternal pre-pregnancy body mass index and categorized women into obese versus non-obese. This data, maternal pre-pregnancy BMI, was mixed. Some of it was self-reported and some of it was measured. In most cases, the measured weights were done on the heavier women. The Ottawa Civic does have a clinic where they see heavier patients, and so those women had recorded heights and weights as opposed to self-report. The outcome variables fell into two major categories, the first being maternal intrapartum and postpartum variables, and the second being fetal, neonatal, intrapartum, and resuscitation variables. Next slide. We had to choose a primary outcome variable, and a fair amount of discussion went into this. And at the end of the day, we ended up deciding to use rate of cesarean section overall for any indication. And then we included other maternal outcomes, such as induction of labor, labor augmentation, prolonged second stage, assisted vaginal delivery, cesarean section, and cesarean section was broken down then into all indications and then several subgroup indications as well. And we looked at regional anesthesia use under maternal outcomes. Fetal outcomes consisted of fetal monitoring, presence of meconium, cord artery base excess greater than 12, and level of neonatal resuscitation. These are the ones that we were actually able to analyze. We did have more outcomes that we were interested in looking at. However, there was risk of de-identification, and we were not able to do so. Next slide. The statistical analyses, first of all, for the descriptive statistics, it was pretty straightforward. We used Fisher's exact and t-test. And then most of the energy was spent on performing multivariate logistic regression modeling. Next slide. First of all, macrosomia certainly was common. We had 6,960 births at the Ottawa Civic Hospital in that time, 835 of which had a baby that weighed more than 4,000 grams for a total of 12%. If you just looked at those 835 macrosomic infants, 240 came from obese mothers. And so that worked out to 29% of all macrosomic infants had a mother whose body mass index was more than 30. Next slide. The overall demographics for that cohort are kind of interesting. So in total, 4% of women were underweight, 53% were normal weight, and then the remainder fell in either the overweight or the obese category. And so that data is pretty consistent with the Canadian Health Measures data that I showed you earlier. So we had 1,328 women who fell into our exposure group. Next slide. This data looks at comparing infants who were sort of an acceptable birth weight and then those that fell over 4,000 grams. And it breaks them down into their maternal BMI class. So if you compare underweight, 4.4% of babies were non-macrosomic and came from an underweight mother, and 1.7 actually of the macrosomic infants came from underweight mothers. And so that makes sense, I think. You can see that the data for normal weight women is pretty consistent. As we move to overweight and obese mothers, there's a big difference in whether the baby's non-macrosomic or macrosomic. If you look at obese isolated, overall 17.8% of non-macrosomic babies were born to obese women, compared to 28.7% of macrosomic infants. And next slide. So this is just the overall demographic data, and I've highlighted in green the part that turned out to be statistically significant. And this should be pretty straightforward and makes sense. So first of all, gestational age at delivery, we wondered whether that would be different for a macrosomic baby, depending on whether their mother was obese or not. And it turned out that it was. So macrosomic infants were more likely to come from obese mothers and were more likely to be born at an earlier gestational age. Initially, you might wonder why that is, but it probably makes sense. If you consider that obese mothers, A, are more likely to have health complications related to their obesity, so something like gestational hypertension or preeclampsia that's going to prompt delivery a little bit earlier. And if you also consider that obstetricians tend to get a little bit more leery of obese mothers and the concern regarding macrosomia. And so we tend to step in and intervene earlier in those patients. The second one there is BMI pre-pregnancy. This is the way it should be, I think. We looked, remember, at obese versus non-obese. So in our non-obese group, the average BMI was 24, and in our obese group, it was 36. The heights are fairly similar if you break BMI down into height and pre-pregnancy weight. The obese mothers did tend to be a little bit taller if they produced a macrosomic infant. And pre-pregnancy weights, this one I still find amazing. The pre-pregnancy weight for the non-obese mothers was 67 kilos compared to 100 for the obese mothers. So we're not talking about sort of a small difference between our non-obese and our obese women. These are women who are substantially heavier. Next slide. This shows gestational diabetes and gestational hypertension at the top there. So again, if you're a macrosomic infant with an obese mother, it's far more likely that that pregnancy was complicated with gestational diabetes or gestational hypertension. Probably not a surprise to anybody who cares for these patients. The smoking in pregnancy data is a little bit interesting. If you're a macrosomic baby, so more than 4,000 grams, and your mother is obese, you're more likely to have been exposed to cigarette smoking during pregnancy. And that's almost a threefold difference present there. It's long been debated whether socioeconomic status is a contributor to obesity. We do recognize that smoking certainly is more common in both low socioeconomic status and obesity. And then there's a school of thought that perhaps this smoking is an attempt by these patients to actually limit their weight or their weight gain during pregnancy. It's interesting to me that when you look at the birth weights of the babies overall, so remember, these are all macrosomic infants. We're just looking at whether they had a non-obese mother or an obese mother. In general, the weight is always going to be higher in those babies who come from an obese mother. So if you look at mean birth weight, it was 4,268 grams. If your mother was non-obese, it was 4,328 if your mother was obese. If you look at large for gestational age, there we're looking at 68% in the non-obese mothers and 84% in the obese mothers. Macrosomia 1, of course, we can't compare because we use that as the variable for comparison. But macrosomia 2 now, birth weight greater than 4,500 grams, those babies tend to come from mothers who are obese at a 25% rate there. Next slide. When we looked at outcomes, and we're going to look at this more in detail in the next slide, we found that women who had a macrosomic baby were more likely to be obese and be induced with an adjusted odds ratio of 1.42. They were also more likely to undergo cesarean section for all indications combined together, as well as when you broke it out by maternal indication. And again, maybe that's not that surprising. If a mother is obese and the baby is suspected to be macrosomic, and you throw another complication on there, something like eclampsia or preeclampsia or gestational diabetes, you're more likely to jump to cesarean section in those patients. Next slide. Really busy, and I don't intend for you to work your way all the way through this. I've highlighted the measures that we talked about a moment ago. Some of them are interesting to glance at. If you look under cesarean section delivery, so that's the second green category there, all indications at the top. I already told you the adjusted odds ratio was 1.45. We also looked at measures like failure to progress or descend, non-reassuring fetal heart rate, and breech presentation. And those indications for cesarean section were not significant. One that we were quite interested in looking at but did not have enough data to prevent re-identification was suspected macrosomia and maternal request. We were not able to analyze either of those, but those would make sense also to be a little bit higher. Next slide. And then we looked at the fetal and neonatal outcomes and found that there was no difference in intrapartum monitoring. And I guess that surprised me. I suspected that obese women would require internal monitoring more frequently, but they did not. We did find that macrosomic babies were less likely to avoid resuscitation. Kind of a little bit of a backwards way to write that, but so they're less likely to avoid resuscitation. and that was 36% less likely. As well, they were more likely to require free-flow oxygen, 57% more. So remember, this is 2 macrosomic infants, and we're just looking at whether they were resuscitated differently depending if their mother was obese or non-obese. And then finally, we did note a trend toward increased need for ventilation and intubation, but just did not have the numbers to reach statistical significance. And the next slide will show a similar chart for neonatal outcomes. Again, in green are the variables that were significant. If you scan down just below that, you'll see positive pressure ventilation and intubation. So positive pressure ventilation, the adjusted odds ratio was 1.57, not significant. As well, intubation 1.68 and not significant. Next slide. The question was posed to me actually by one of my reviewers. They were interested in knowing whether a macrosomic infant from an obese mother was more likely to be delivered by cesarean section if the mother had diabetes. So we spent a little bit of time working our way through that and discovered that actually that's not the case. It didn't seem to make much of a difference whether there was gestational diabetes, and that does include type 1 and type 2 diabetes as well. Next slide. And the second question they posed was, well, then what about gestational hypertension? And so we ran a similar analysis there and found that, again, there was not a significant difference in cesarean section for any indication. The adjusted odds ratio and the confidence interval show that. But if you look at cesarean delivery for maternal indication, in the case of gestational hypertension, then certainly if you're obese, you are more likely to undergo cesarean section than if you are non-obese. Next slide. Oh, that was meant to come up in two different moments, but it doesn't happen here. So first of all, we want to look at whether we can improve neonatal outcomes for these mothers and infants. And this is something that's been long debated. Macrosomia, as you all recognize, is extremely difficult to diagnose prenatally. There's always a margin of error when you do ultrasound, and our margin of error tends to be highest in our heaviest mothers and in our heaviest babies. And so when we talk about intervening based on prenatal diagnosis of macrosomia, that doesn't turn out to be all that promising. In general, there's absolutely no intervention that's going to make a big difference in these babies. I think it's worth, underneath the elephant, it asks obstetricians to discuss with all patients, not only those who are obese, but all patients, the importance of healthy lifestyle choices, diet and physical activity during pregnancy. I am absolutely guilty of focusing on gestational weight gain. I do that with my patients in the clinic, and I think it's still important, and I think that they need to be conscious of their target gestational weight gain as well as the outcomes associated with excessive weight gain. And yet those women that have had the most success as I've worked through their pregnancies with them are those that really have looked at making healthy diet and physical activity choices rather than focusing on weight. And as always, balance is the key to life for all of us. Next slide. Perhaps it's worth both obstetricians and our neonatal colleagues anticipating macrosomia among women who are obese, particularly if they undergo induction of labor or cesarean section. That really, I don't think, should be a surprise diagnosis to anybody. Next slide. And then most importantly, it's worth recognizing that if a macrosomic baby is born and the mother is obese, there's a higher risk of complications in the delivery room. We've had a lot of debate here at our hospital about whether we should have neonatal support at all deliveries where the mother is obese. And that kind of goes back and forth depending on who's on. But it does seem that we run into more problems with the babies of our obese mothers, especially if those babies are large. And next slide. Some of you might know that piece of art down in the right-hand corner. It's, of course, in Ottawa. It looks really quite small there, but the sculpture called A Girl is massive. And if you ever get the chance to see it, it's worth dropping by. We looked then at our conclusions and our future work, and I think it's clear that maternal obesity is clearly associated with fetal overgrowth. It also can be said that there is an additive effect of obesity and fetal overgrowth on adverse outcomes, particularly induction of labor, cesarean section, and need for neonatal resuscitation. And in the future, I hope that we will be developing interventions that are going to decrease the incidence, first of all, of maternal obesity, and secondly, of macrosomia. And next slide. A few people that I need to acknowledge in the work that was done. My thesis supervisors were Mark Walker and Shiwu Wen. Poor Zach Ferrero helped me out in doing the review of all 289 articles for the systematic review. Zhao En-Tu and Huiling Cao helped me out with the analysis on our cohort studies, and Anne Sprague was instrumental in helping me get at this data from the BORN data set. Next slide. And that takes us to the end, so we're ready for questions and discussion.
Thanks so much, Laura. Really interesting presentation. I'll go to the chat box, the upper left corner of the screen. So if any of you have questions, please think about them. You can now type them into the chat box, and we'll try to scroll through. We have a few minutes left. So I'll just start up to acknowledge the issue. The midwives of Chatham seem to have had trouble logging on to see the slides. I'm sorry for that. Please know that the slide deck will be posted on the BORN website, so you will be able to get the information. It'll take a few days to get it posted, but you can look for it there. So we have a question here. I think you did talk about the quality of the studies you reviewed, so you perhaps have answered this, Laura, but Becky asked, did you assess the quality of the studies included in the systematic review? You want to add anything over and above what you've mentioned?
Yeah, no, I can add a little bit of detail. We did look at study quality, and that became, I guess, enlightening as we looked at that. We used the Newcastle-Ottawa Quality Assessment Scale, sort of your standard recognized criteria grading scale, and we looked at several different factors in our study to decide whether they were high or low or moderate quality. I can tell you what those criteria were. We looked at representativeness of the exposed cohort as well as the non-exposed cohort. We looked at how the exposure was ascertained. So in this case, because it was obesity, we looked at whether it was self-report or whether it was actually measured data. And we considered measured data to be a necessary requirement for a study to be graded as high quality. We also looked at whether the cohorts were comparable, and we looked at adequacy of follow-up. So first of all, the study was considered to have a high risk of bias if there was a major methodologic flaw in the study, and a low risk of bias if there was a measured first trimester weight and there were no major methodological flaws. So you could be a high-quality study if height and weight were measured and more than 4 of the quality assessment criteria were rated as high, and then moderate were sort of slightly less rigorous, and low-quality studies were those where height and weight were self-reported and there were more than 3 quality assessment criteria that posed a significant risk. So we did that independently by both reviewers, and then we resolved all discrepancies by consensus.
Okay, that's great. Becky also asks, she's curious to know the future short and long-term health consequences of being born macrosomic. Have you any information you can share about that?
Yeah, so that's more stuff that came up in the literature review for this project. There certainly are short and long-term health consequences. If you're a large baby and you're born really either vaginally or by cesarean section, the risk of birth trauma is substantially higher. So these are the babies that get into trouble with shoulder dystocia and the resulting injuries from those. These are babies that are more likely to go to a neonatal intensive care unit. Our NICU admits all babies who are born over 4,000 grams, even if it's just for a short period of time. And mostly what they're looking at there is neonatal hypoglycemia, a significant problem in these bigger babies. Also, it seems that tends to occur more commonly if the mothers are obese, and certainly if they had gestational diabetes. Long-term health consequences, this is interesting. I think it tends to get to the same underlying root of the question of can there be healthy obese people and can there be unhealthy obese people? And I think that's certainly true. I've now been staging the patients who come into my clinic, and so they range from stage 0 to, thankfully I haven't had any stage 4s yet, but I imagine someday I will. I think when you're macrosomic, it's the same kind of an idea. Some babies are macrosomic. They're completely healthy and genetically meant to be more than 4,000 grams or greater than the 90th percentile. But then there's going to be a group of those that are that weight because of underlying metabolic issues and metabolic differences. And we can see that that persists not only through the newborn period, but into childhood and into adulthood as well. So a macrosomic infant is more likely to struggle with obesity throughout their life, more likely to have problems with diabetes, high blood pressure, cholesterol, and heart disease as well.
A third question from Becky is, do you think gestational weight gain may be a confounder to these findings?
Yeah, I think that's entirely possible. Using the data set that we had, we couldn't actually look at gestational weight gain. It would be really interesting to have that data and to work that out a little bit more. I do think probably it plays a confounding role.
Okay, and Sharon asks, do you recommend referral of mom to dietitian, pediatrician, I just have to scroll back here, pediatrician, anesthetist, or do you think this is on a case-by-case basis? This is necessary on a case-by-case basis.
Yeah, I think it almost has to be case-by-case. I'm not sure about your population, but my population, I have to be somewhat, I have to exercise discretion in who I send for referral, only because I have so many patients. Our obesity clinic that we run here, we have to use BMI of 40 as a cutoff to get in. Otherwise, we get completely overwhelmed. And so I think if you have the resources, fantastic, refer anybody who's obese to all of these people. In reality, I think you have to triage your patients to maximize your resources. So if you have a mother who's diabetic or hypertensive and obese and seems to be measuring large either clinically or by ultrasound, those are the people I think it is probably necessary that they get some advanced discussion.
Oh, sorry. Okay, we have a question from Rouge Valley Midwives. We were curious about the association between macrosomia and hypertension in non-obese mothers. Isn't hypertension usually associated to intrauterine growth restriction or small for gestational age?
I think that's a fabulous question. I'm curious about that too. Certainly hypertension causes IUGR and small for gestational age, but it seems almost like, in a way, there's a bit of a protective effect of obesity here, kind of like smoking and preeclampsia. We don't want to advertise that there may be something that is beneficial about being obese, but probably the association between hypertension and IUGR and small for gestational age is negated in this population. When you look at all women who are obese, we tend to think about the large babies. There are a proportion of obese women who go on to have IUGR babies. And in those ones, that I have it on my list of things to look into someday, I think there's probably a much bigger long-term metabolic consequence to those babies than to the ones who are actually born large.
Sorry.
Oh, it's okay.
Okay, Sharon asks, do you think the normal gestational weight gain should be encouraged to be less in these women?
Now, there's something I've thought a lot about, and the reason I've thought a lot about it is because I had a patient challenge me on it. So when you look at gestational weight gain in women whose BMI is over 30, you can use either the Institute of Medicine or the SOGC guidelines. I tend to use 15-pound maximum weight gain as a suggestion. But if you take women whose BMI is over 40, there are a couple of pretty good studies that show that the best pregnancy outcomes happen in women who actually lose weight during pregnancy. And I was a bit taken aback by that. The idea of telling somebody not to gain weight, never mind to lose weight during pregnancy, seems a bit frightening, I guess. My suspicion is that in those women whose BMIs are over 40, when the best pregnancy outcomes occur because they're making good diet and physical activity choices. And so they're improving their overall health status. And if that's the reason why they're losing weight rather than by restricting, it probably doesn't have the same consequences. So I've had a number of women now come through the clinic who've lost weight, and some of them actually not insignificant amounts of weight. I've got a couple that have lost about 30 pounds through the course of their pregnancy, and they have had really uncomplicated pregnancies with normal weight babies. It's something I do very cautiously. If my patients are not gaining or losing weight during their pregnancy, we follow growth of those babies very carefully. That's my thought.
Okay. Anne Sprague's actually sent a message to say that we want to remind you or let people know that gestational weight gain is a new data element in the Born Information System as of April 2012 when the new system came online, and so more research will be possible given the data that is collected. And it's just to make a plug also for those midwifery practice groups and hospital user groups who are entering data for their clients into the Born Information System to make sure you get that information in a timely fashion as accurately as you can, because it will help to inform future directions for practice and research, and to help you identify issues in relation to the populations you serve as well. So, good point, Anne. Yeah. I just had a thought. I've scrolled to the end of the questions in the chat box right now, but we'll just give it a minute in case anybody else can think of anything. And I was just going to ask you, Laura, if you were to leave us with sort of three key messages from a practice perspective, from implications for practice, both with antenatal care providers for women before they deliver, perhaps, and for those care providers who care for the babies after birth in relation to complications. What would be your three take-home messages that you would want people to go away with thinking about with respect to this population?
Always tough to come up with three on the spot.
Well, one would be fine.
Regarding prenatal care, I think, first of all, it's important to anticipate a macrosomic baby, whether it's coming from a normal weight woman or whether it's coming from an obese woman. I think your index of suspicion needs to be higher in your heavier mothers, and I think that those women who are obese need to be aware that that is a real risk. And really, when you get talking to them, most of them know that, and they know it from a family perspective, because they say, I weighed 12 pounds when I was born. My sisters had 3 babies that weighed 12 pounds. Why would mine be any different? Mm-hmm. So I think index of suspicion is important. As we already talked about, there's no real reliable way to predict when you're going to get a baby who is much larger than anticipated. But I think it's important to be conscious of it and to at least be aware, especially in the prenatal period. And then when it comes to intrapartum management, I think those of us that deliver babies, I think we need to be conscious of the whole picture. If you have an obese mother with gestational diabetes, then macrosomia is actually pretty likely. And so the challenge to that is recognizing that it's pretty likely and then managing labor and delivery in an appropriate way. We've all had terror struck in our hearts when dealing with an obese patient or a non-obese patient who has a macrosomic baby with a shoulder dystocia, and you're struggling your way through that. None of us want to be there, and yet until you actually put that mother and that pelvis and that baby through a trial of labor and delivery, it's really hard to know who's going to have an uncomplicated delivery and who's going to have a complicated one. And it's probably worth us making our patients aware that there's no hard and fast rule here. There's no way to know ahead of time, and that birth complications are possible and will be dealt with in the best way possible. It's challenging to present that information in a way that doesn't immediately lead the patient to say, well, then you better do a C-section. because I don't think that's the answer either. And then when it comes to care in the delivery room, we don't know why the macrosomic babies whose mothers were obese required more intervention than those that did not. But it was a consistent finding. And so I would say if you're at the perineum and you deliver a baby that looks to you to be more than 4,000 grams, particularly if it comes from an obese mother, you may want to call for some support in that situation. I guess that's my 3 messages for you today.
And great key messages they were, too. That's wonderful. Thank you. We just have a comment here from Caitlin Johnson, and it reads, this is Caitlin, and an epidemiologist from the York region. Gestational weight gain and maternal obesity are indicators that are being built into or are being built by the Reproductive Health Working Group of the Association of Public Health Epidemiologists in Ontario currently. And I know Sherry is involved with that group. I don't know if you want to comment more, Sherry.
Great. No, thank you. So this is Sherry, an epidemiologist from Born, Ontario, and I sit on that working group. And exactly like Caitlin just mentioned, those 2 indicators are being built into the core set of indicators from AFIO, the Public Health Advances Working Ontario Association. And Born data will help to inform those 2 indicators, as Anne mentioned, when a significant amount of data is collected as of April 1st, 2012 from the Born information system. So thank you, Caitlin.
Okay, it looks like we have come to the end of the chat box. Are there any other thoughts you would like to leave the group with, Laura, or have you made all the comments you can think of at this point?
I think we've been through all the major points. I certainly thank everybody on the line for first of all, listening, and second of all, for interacting. I think that's great.
Okay. Well, I think we'll go ahead. We're a little bit early, just 5 minutes early, but it looks like we've satisfied everybody's needs for today as far as questions. So on behalf of all of us, the listeners and Born Ontario, I'd like to say a big thanks to Laura for taking the time and speaking with us from her home in New Brunswick. It's been a very enlightening talk. Again, the information will be posted on the Born website for you to access in the future. You can let your colleagues know who weren't able to attend today. We thank everybody for joining us. Stay tuned for our final Born provincial rounds in June. We will be canceling rounds for July and August because of summer vacation and people busy with different activities. But we'll have our final session in June. We'll be sending out announcements about that session early in June as we normally do. So stay tuned for that topic. I'll say goodbye to everybody. Have a wonderful afternoon, and thank you so much for joining us. Bye now.